Okay, ladies and gentlemen, conference organizers, thank you for the opportunity to speak to you today in this session. So I'll take a slightly different approach to my presentation than the previous speaker. Maybe what I'll make clear from the beginning is that what I will be speaking of is a government policy in Finland, the types of measures, and I'll try to show you with some examples on what the effect of that policy has been. It's a prevention policy. I'll discuss a little bit on what grounds that policy actually was put in place in the late 90s and the early 2000s. And we are talking about harm reduction and basically for prevention of infections among persons who inject drugs. This is a discussion that in the drug policy discussion sometimes is forgotten because actually a very large proportion of the disease burden that comes from illicit drug use, especially the injecting drugs, comes from infectious diseases that are transmitted through risky practices of injection, which are all totally avoidable with fairly simple measures, which are not too expensive and do not have any effect on the actual demand for drug use. That's a separate question. So let me put it quite clear from the beginning that from a sort of policy point of view, of course, it's always better to prevent the root cause of any harm to society. So that goes without saying that policies that diminish the use of alcohol, tobacco, and illicit drugs, which are effective, are of course things that you have to do. That's clear. At the same time, you have to acknowledge that if you have a population that has a problem, you have to deal with that problem too. You can't just sort of think that, all right, by prevention we will get that problem go away. Maybe, but that may take 25 years. So that's why you have to have this multi-sectoral approach that takes into account primary prevention, secondary prevention, tertiary prevention, of course treatment. All of it needs to be there. And then the last point I'd like to say, drug use and the infectious diseases which are linked to it are highly poverty linked diseases in many parts of the world. In any place where you look at this issue, drug use and infectious disease are much higher incidence in people who are outside society because of poverty. So that's another thing that you have to remember, because addressing poverty, of course, is a very strong way of addressing these problems too. So I'll just give you an example. Now there are lots of good guidances out there which actually list effective evidence-based methods for preventing harms that are due to illicit drug use. And especially if you talk about infectious diseases, there are many of them. UNODC has them, UNAIDS has them, the WHO has them. There's one which the ECDC and the EMCDDA from the European perspective put together a couple of years ago. And they're pretty similar. If you look at the content of them, in this version you have 7 key recommended interventions. Some others have 9, some others have 15. Basically they are more or less the same. They deal with the concrete risks and what you can do to prevent those risks and how you can do it. So in the EMCDDA, ECDC guidance, you have injection equipment provision, you have vaccination, you have drug dependence treatment, you have testing, you have infectious disease treatment, you have health promotion activities and targeted delivery of services. And all of these are important and they need to be used in combination. In some of the other guidances, there's a couple of additional ones, although they go into each other a little bit. Now for the actual sort of building of these services, it's important to have sort of a base to work from. And I'll remind you that these these guidances that I'm talking about here, the MCDD, ECDC guidances, those were actually based on a very comprehensive evidence review. So, so hundreds of scientific publications of various types of interventions were looked through and graded in a highly actually conservative manner to tease out the evidence base. And things that come out of that is that there are key factors to actually successful implementation of harm reduction functions, where you actually make sure that acknowledging that there is drug use, acknowledging that we will not get rid of it overnight, and what can you do to minimize the harm, both for the individual and for society. And a couple of very important things come out. You have to be pragmatic. I mean, it's better to be pragmatic in this case than idealistic. If you put your ideal as a totally drug-free society, you can pretty much stop there, because that then prevents this approach. The client's rights are actually more important than perhaps the implementer's rights. You have to have public health objectives when you talk about infectious diseases. That's quite clear. Would go for the drug use also, and that these were based on scientific evidence and experience also for certain areas of the work where it's more difficult to find actually proper studies. But that leads into principles of the service provision. Confidentiality, I cannot stress this too much. If you don't have the confidentiality and the trust of the clientele, they simply won't come. I mean, it's like the mentioning, I think Sauli has mentioned, you can't have the doctor just sit and wait for the individuals to come. They won't come. You have to find them, and you have to find earn their respect and their confidence, and that's the only way. That means that you have to make the services actually accessible. I mean, if they are somewhere in a posh neighborhood, in the third floor, behind 5 guards, that's not going to work. You have to make them available there where the users are. Should go without saying that you have to have a user-friendly atmosphere, but we put it there because it's such an important thing. You have to have a dialogue because things change over time, and they can change quickly. I think the new type of psychoactive substances are a clear indication of how quickly things change. Practical approach in the provision of services, so not too much bureaucracy. Most people don't have a lot of patience with that, and people who have to use much of their time to actually fund their use have even less. So I think that's quite practical. And you have to, in this type of services, refrain from moral and ideological judgment. And that's tricky for anybody, of course, especially from the health field, but it's quite important. And you have to be realistic in your goals. Yes, of course, obviously, would be wonderful if everybody stops the drug use, but that is, again, perhaps unrealistic to expect in a very short term. So you have to respect that some people will want to use the drugs, and that's then, in a way, their choice, even if we don't necessarily condone that. So if we look a little bit on where we are with bloodborne infections and TB among persons who inject drugs, and I'm mentioning TB specifically because it's highly linked, unfortunately, in these population groups. Tuberculosis in some parts of Europe, not every part, but in many. It's again the question of poverty, which comes up. And you can see that there is an uneven distribution in Europe, both for HIV, for TB. I could add hepatitis here, and it would look pretty much the same. And all of these, in one way or another, either directly through bloodborne transmission or through the poverty relation, have a link also to injecting drug use. And there's just another way of looking at that. The previous one was incidence based on population. But if you look actually among people, the numbers of people who actually inject, it's a little bit different. And you can see that, for example, in the Iberian Peninsula, there's fairly high numbers. Most of this is actually something that happened in the past. And that just reminds you of the time perspectives that you have to have. These are chronic infections. They are not disappearing overnight. And most of the Spanish and the Portuguese epidemics happened in the 80s. And that means that their prevalence has come down significantly, but it's still high. We can take Estonia as another example. The same thing there. I mean, you're going to be working with this issue for decades and not just years. There's no way around that. So we did something in the 90s in Finland. We put together a government policy that tries to combine, and I think we can claim that fairly successfully did so, combine control policies. We have quite strict control policies on drugs. We have no legalization of drug use. I think actually that should be considered, but that's a different thing. Not selling, but using. That's a different story. I won't go into that detail. But what we did is that we created targeted services for people who inject drugs, so-called low-threshold health service centers. We have them at the moment, the last number is on 38 municipalities, and they have a different type of service mix, a little bit depending on the municipality, but they have health advice, exchange of injection equipment, vaccinations, low-threshold testing, some offer food and some shelter even, small-scale outpatient services, such as, for example, pregnancy prevention services for women are provided by some, and so on. And they do lots of outreach and peer-to-peer work, and that's quite important too. And then we have referrals to the sort of next level of services. These are municipal responsibilities, as all primary healthcare in Finland. We actually have a provision in the law that says that municipalities have to provide health prevention services, including injection exchange. That's in the law. And that stopped the legal debate in Finland about these services. I should mention that this would not work without the very, very tight and continuous cooperation with the NGO sector. Most of these are done by non-state actors, non-municipal actors, but the purchasing is done by the municipality. And this is just because these actors usually have a much better understanding of the actual day-to-day problems of the target group. I'm not saying that municipal actors could not do it, but it's usually more difficult to find them. So what we did after a number of years, that we actually evaluated these services. That was done already in 2008, or finished in 2008, and we looked at the prevention of bloodborne diseases especially. This can be found on the web. It's actually available in Finnish, Swedish, English, and Russian, because some partners translated into Russian also. So we looked at some effectiveness indicators, impact indicators in the changes in the prevalence and incidence of bloodborne infections. This is sort of very short term because changes in these indicators take, as I said, many, many years. But we looked at them anyway. But also asking the opposite question, we had low prevalence of HIV, could we sustain that? Negative effects, if we could see anything of that. We had targets in the government policy that we looked at. There were 3 different scenarios, and we looked at which one actually happened. And then coverage and some economical indicators. That was pretty crude, but I'll show you one slide on that, which might be interesting. So if we looked at the coverage indicators here, the numbers on proportion of IDU reached, we have done quite some work on doing capture-recapture studies in registers to look at the number of problem drug users. We have about 20,000. That's fairly stable, not much change over the years, unfortunately. We'd like to see it go down, but the reality is that it doesn't. The coverage we had was about 70.8 at that time. It has gone up since then, actually, which is good news. The target was 60, so that was okay. Regional coverage was at that time partly met. It's still partly met. We still have some regions of the country that don't have these. The half of the calculated need was met. We made a calculation based on injection frequency, and if you want to cover every single injection, we had a number, and we met about half of that at that time. Now we actually meet the full scale. We exchanged about 2 million syringes and needles a year. At this time, now it's 4.5 million. Return rates, 98. We actually demand return, and it's not a problem. We get more back. It's actually higher than 98, because we have sales in pharmacies, and the people bring in more. It's about 102, actually. So that's actually not so bad. Acceptance is high. About, as I said, about 70% use the services. And we have the testing, and we set the target of testing at least 10 to 15%. 10% within the system, and we reach 10 to 15 depending on the service. So we had 3 scenarios in this government program: worsening situation, unchanged, or improved situation. Worsening would be more than 100 cases annually. That's a bit modest, actually, I think. But people actually thought that would be absolutely terrible at the time. Unchanged and improved. And what actually came about was that the situation was improved. I'll show you the numbers in a second. Looked at cost effectiveness and did some modeling. Not very sophisticated, but this is simple, and these are direct cost of treatment only. If you would add all the social costs, the loss of income, the hospital care, you could put one more zero on that number. We get a return of investment which is about 46 times. So this is very cost effective if you talk about it with politicians, which they usually like that. So in that regard, we think we actually made a good investment. Costs about 5 million a year to do it. That's not much in the total numbers. This is what it looks like. This is not proof of effect, but you can't sort of ignore the correlation in the annual rate of infection and the equipment exchange. So as I said, this is already a couple of years old. We're up to 4.5 million exchanges. And we don't have we don't give out sort of unlimited numbers. You have to earn the number of needles, but you always get some, even if you couldn't exchange. So it's not absolute exchange. And I'll just show the last slide, because here you actually see the incidence in Finland. If you look back, this is that peak of the epidemic that we had in 1999. It's the red line there. A neighboring country epidemic that started similar services, but 3 years late. And that's the sort of outcome difference that you could have in HIV burden. Each of these people with current treatment live a full life, but they have to be on treatment for the whole time. So you can imagine what the cost is, even if you assume that everybody is treated, which you should nowadays. And I was quite worried looking at the numbers from here of the dropout rate, because of our drug users, 98% are on treatment. It has taken a lot of work to achieve that, but it means that you have to actually make the services in such a way that the people can use them. And I'll finish there. Thank you.